Hi. I know I'm standing between everyone and lunch, so we'll try to move through all this. I am a thoracic surgeon here at Rush. I've been here for over 10 years. I trained here, so I have the privilege of working with Dr. Katz's almost every day. So I don't have anything to disclose. So I would like to kind of focus on early stage lung cancer because that's kind of where we're at in thoracic oncology right now. And so this slide here, we're talking about a couple things right now. So early stage lung cancer, we're talking about those nodules that are less than 3 centimeters in size and node negative. On the left, you can see the cost as stage increases with lung cancer. So for a stage 1 lung cancer, our average hospital cost is about $7,000. When you get to stage 4, it's around 20 grand. And so there's a considerable cost difference. 5-year survival data from the most recent ASLAC data is that early stage lung cancer, you can see we're in the 90s for stage 1A1 and still in the upper 70s and 80s for 1A3. And you can see considerably decreases as we get out of that early stage category. So again, early stage lung cancer, we're talking about a single tumor less than 3 centimeters in size, confined to a single portion of the lung and no lymph node involvement. So what do we do with surgery? Well, we're trying to remove the tumor and any affected tissue, leaving healthy margins and preserving as much healthy lung tissue as possible. So parenchymal sparing surgery. There's different types of surgery that we use for the treatment of lung cancer. You have your standard lobectomy, in which we remove one of the 5 lobes of the lung. There's a wedge resection, which is just removing a portion of one of those lobes. A pneumonectomy, which is taking the entire lung, and then a segmentectomy, which is removing an anatomic portion of one of the lobes. The type of surgery depends on the location, the tumor, and the overall health of the patient. So there's a new paradigm in the treatment of early stage lung cancer, and this is kind of a big shift. And we waited on this data for the better part of 20 years, but it finally is here. I wish I had a slide like Jimmy that says that it's here, but it's here now. And so the shift is that we're in a parenchymal sparing mode, and that is people are living longer. The outcomes of early stage lung cancer are better, and so we're preserving lung tissue with surgery. And so this Al-Torki study was published in the last year showing that the outcomes for sublobar resection are equal to those of lobar resection for early stage lung cancer. And that's kind of been a game changer in the treatment of early stage lung cancer. So when we talk about parenchymal sparing procedures, we have wedge resections, and that's generally for tumors that are less than 2 centimeters in size that are in the periphery of the lung and node negative disease. Segments, same situation, but we need to know that it's confined to that segment of the lung with an adequate margin if we just take the segment. And then sleeve resections is for more central tumors where we're kind of putting the airways back together when it's sitting in a segment of the airway. And then we have anatomic resections where we're talking about the lobectomies and pneumonectomies, and segmentectomies actually fall into this category as well, but they're parenchymal sparing procedures. So here's that data that I was talking about sublobar resections versus lobectomies. We can see that for overall pulmonary function, we have improvement in the pulmonary function for sublobar resections, but where we're really looking is at our disease-free survival, 5-year survival, and quality of life, and that those all kind of follow the same trajectory between the two types of resection. So what happens after surgery? So we have national average and then what we do here at Rush. And so you can see that for a sublobar resection, our postoperative length of stay is about a day. For a lobectomy, it's around 2.3 days. And I think our newest data is that it's down to about 1.9 days. And then pneumonectomies, our average length of stay is about 5 days. Our complication rates are low. And when we decide what kind of surgery we're going to do, we look at the patient as a whole. And some of that also goes into saying that someone's not a surgical candidate. And then we get Sarah and her colleagues involved for SBRT because outcomes are just as good for that patient that won't tolerate an operation. So where we're at, the far left, that's your traditional thoracotomy. And, even 5 years ago, 40% of thoracic surgeons in the country were still doing thoracotomies for lobectomies and early stage lung cancer. Then we kind of moved on to video assisted surgery, camera, small incisions, and now we're in the era of the robots. And so the Da Vinci surgery is also camera, small incisions. Same sort of situation, except you take from being at the table with your camera to being the camera's at the table and you're at a console that you can see out in the lobby here, but equal outcomes for the two platforms. So why minimally invasive? So minimally invasive surgery for early stage lung cancer is standard of care. So in 2024, you should be getting a minimally invasive lobe anatomic or sublobar resection for your early stage lung cancer. We have a smaller incisions, which decrease the inflammatory response. There's a reduction in blood loss and need for blood transfusions, shorter length of stay. National average 5 versus 8 days. Our averages you saw are more like 1 to 2 days. Everybody's back to work and within about 2 weeks. Most people tell me that they feel back to normal after about 7 days after having a major lung resection, and then improved outcomes, decreased complications, and increased overall survival. So VATS versus rats, and I can't stand that term, but robotic assisted surgery. So, a traditional video assisted thoracoscopy, you have one port for the camera, usually an additional port for retraction, and then a small access incision that most of the operation is done through and the specimen's actually removed through. For robotic platform, it's generally 4 to 5 incisions about the size of the tip of my thumb. One of those ports gets enlarged a bit to remove the specimen. And, you use CO2 insufflation, which helps in the dissection. And then it gives the operator the ability to control the camera by yourself. And then also gives you an extra hand. So I go from having 2 hands to actually having 3 hands, which makes my life a little bit easier most of the time. But minimally invasive surgery is minimally invasive surgery. There's no difference between the outcomes. Whether you're getting a thoracotomy or a minimally invasive surgery, position is the same. Everyone goes lateral. The arm position is a little bit different. The up and out is a video assisted position, and that is because it opens the anterior chest wall for the access incision. With the Da Vinci platform, the arm is actually down and lower because otherwise the robot arms would be, knocking off the person's arm, and that wouldn't be good. We probably would get dinged for that. So that's at the table. So you're standing at the table. The top left is general instruments that we use in VATS surgery. You can see bottom left, that's kind of the setup with ports in. You're standing at the table with 2 monitors. It helps if you have a separate person to run the camera, a separate assistant. It involves a couple more skilled people. Hopefully this works. Is there a mouse or something that'll make this play? Yeah. Great. Okay, so this is a typical VATS lobectomy. So this is the inferior pulmonary ligament. This is a right-sided resection. Now we're in the fissure, exposing a lymph node that's overlying the pulmonary artery. That's the pulmonary artery, that white thing. So dissecting out the pulmonary artery, it looks like this is a lower lobe, completing the fissure. Further exposing the pulmonary artery. So that's the lower lobe artery. Superior segmental artery is the one in the top of the screen, basilar segments. Now isolating that lower lobe pulmonary artery. And then staple ligating. Completing the anterior portion of the fissure. Taking the vein. It's a little bloody. This wasn't my case. Okay. All right, so versus robotic platform. So robotic platform, so the top left is the equipment involved. The bottom left is typical of what you would look like once you're prepped and draped. Middle slide is what the ports look like in the body. The assistant port is actually a fancy insufflation technology that allows us to suction and continuous insufflation, which makes life a lot easier. And then the surgeon's at the console, away from the table, operating all forearms. Can we click again? So this is a robotic lobe. And so, so again, all operations kind of start in the same vein. We take the ligament to do a thorough lymph node dissection. This is coming up the back. That's taking the level 7 from the subcarinal space. Looking at the airway posteriorly with the azygous vein elevated. Now they're in the fissure. Again, completing the posterior fissure, which exposes the posterior ascending artery to the upper lobe. Transecting, they're taking the bronchus from behind, so the airway to the upper lobe. The vein from the front. And then the first branch of the PA to the upper lobe. I guess we're taking another vein for some reason. And then we have our lobe, off, then goes in a bag, gets pulled through the access or the assistant port, and it's out. This is just replay. Okay, can we play this one? So this combines a little bit of what Dr. Katz has discussed. So this is trying to find a nodule in the lobe. This was injected with ICG dye using the ion, which allows us to identify the nodule easy, and then doing a segment based on the location of the nodule. So preoperatively, Dr. Katzis would come in, he localizes the nodule, he injects the nodule with a radiotracer dye that lets us see it under a blacklight technology through the robot, allows us to mark the nodule when it's not as easy to identify within the parenchymal tissue. This is a left-sided resection. See the aorta pulsing away. Taking the airway. And then just the segmental fissure there to finish. And we're leaving the majority of the lobe behind. So parenchymal sparing procedure for a small nodule. In the bag and out it goes. So that's a very nice actually pic. So arch of the aorta coming down, the PA, the ongoing PA is that white thing that's kind of in the center below the arch of the aorta. And then you can see the upper lobe and the lower lobe kind of separated off where the dissection occurred and the staple lines from all the things that were taken. So, okay. So conclusions, lung cancer is one of the most common types of cancer worldwide. Surgical management is critical in early stage lung cancer. Primary goal of surgery, remove the tumor but leave lung behind. Type of surgery is dependent on the patient. Minimally invasive surgery is the gold standard. Send your patients for minimally invasive surgery. That's where we're at. And surgeons are part of the overall care team, and our role changes every day. And then finally, my shameless plug for our Pink and Pearl campaign. I think Annie's going to talk a little bit more about that later, but what is it? We started, so this campaign was actually started in Tennessee, but we're pretty excited about it here. It's kind of using the success of mammography to spearhead women's lung cancer research. We started in October of last year. We started asking women when they were getting their mammogram two intro questions to get them enrolled in lung cancer screening. Annie and Maria call every patient then, and it's been a nice little segue into getting patients that wouldn't otherwise know about lung cancer screening into our program. And we're actually about to present our data from our initial experience, but it's been pretty successful and we're pretty excited about it. So she'll talk about that more later, but Pink and Pearl.
I didn't know you were actually 6'5", but it's so beautiful outside. So I think I just saw the ones outside in flowers. I think you made it.
Question is, so for you all, after Geissen, how long did it take to learn that robotic? What's it like? That it's just so amazing to do that, to have like the skill in your mind and also the being able to use that. It is a very for provider like.
Yeah, so I was trained in VAT surgery coming out of fellowship. I picked up robotic in the last 5 years. So, and now I pretty much have converted mostly to robotic out of mostly need for some of the places that I operate where I don't have a lot of help. And so it kind of takes the needing extra people, and I can do most of it myself with the arms. I think that, like for the Bronx side, I didn't grow up playing video games. I just wasn't a video game player, but I think that if I had, it would have probably helped me a little bit. I mean, it's not, I don't want to dumb it down, but there's really not much difference. And so I think that if you have a baseline video gaming or gaming capability, that you probably would be able to pick it up easier. But I'll let Dr. Katz's, from the standpoint of surgery, it's much more difficult to learn VAT surgery than it is to learn robotic surgery. And so, we see a lot of older people that never learned VAT surgery converting into robot. Cardiac surgeons that want to do some lung surgery will convert into robotic surgery. It's just easier to pick up. And it's intuitive. That's why they're intuitive. So, but yeah.
I always say a toddler could do it. The hard part is if there's divergence when your lesion is not where it's supposed to be.
Thank you.
Anyone else? All right. Enjoy the break. Thanks for.